So once again, good evening, everyone, and good morning to Dr. Marc Swiontkowski and Aiden and Thinesh who are with us today. So we welcome you all for the web seminar on Intertrochanteric Fractures and JBJS Clinical Classroom demo and uh, presentation by Aiden Smith. So I'll be giving you an overview about today's program. So we'll be starting our day, this seminar with a short presentation on JBJS Clinical Classroom, which is an online adaptive learning platform for the orthopedic surgeons. And Dr. Aiden Smith from JBJS, who is the account manager, will be presenting JBJS Clinical Classroom and also showing us the live demo of the platform and how this platform or the online learning system is going to help you in saving time and maximizing your knowledge in orthopedic surgery. So Aiden's presentation will be followed by a Q&A where you can ask Aiden about any questions regarding the platform directly to him. And after Aiden's presentation, we will have Dr. Marc Swiontkowski's seminar on Intertrochanteric Fractures, followed by a Q&A. And after that, we will be showing you how you can take part in the clinical classroom challenge. If you don't know what we have in the clinical classroom challenge, we will be giving you access to the quiz on JBJS Clinical Classroom, where you can take a short quiz on adult hip reconstruction and trauma. And those who are on the top 10 score highest marks in this, they will be getting 90-day access to JBJS Clinical Classroom. So we will show you how you can register for the quiz after the presentation by Dr. Marc. So after that, we will be giving you links to share your feedback about today's event, as well as ask you to submit your request for receiving e-certificates for attending today's seminar. So now I will ask Aiden to start his presentation. Aiden, I am assigning you presenter privileges. So you can start your presentation and share your screen.
Okay, thanks, Amit. Just give it a second to load. Oh, skipped ahead. Can you see my screen?
Yes.
Great. Okay. Hi, everyone. I'm Aiden Smith. I'm the JBJS account manager. I work with institutions to implement and manage Clinical Classroom. So what I'm going to do in this presentation is walk you through Clinical Classroom, what it does and how it can help you. And then I'm happy to take questions as well afterwards. So feel free to write them in the chat. So Clinical Classroom started about 4 years ago. It started with a company called Area 9, which they're based in Denmark, and they have created adaptive technology that we use. And the New England Journal of Medicine partnered with them to create an adaptive learning platform. Theirs is called, well, their name is slipping my mind, but Knowledge Plus is what it's called. And we came in a few years ago and created our own version of Knowledge Plus using the adaptive technology from Area 9. So that's where all these three elements come into play to create Clinical Classroom. So as I said, it is an adaptive platform. It's also metacognitive. So just sort of to unpack both of those terms, adaptive, I think most of us know what that means, and that it essentially learns from you as a user. So your experience in the platform will be a lot different from any of your colleagues' experience. And it's also metacognitive, which means that learning is focused on the areas that you're weak in and not so much in the areas that you're strong in. So the algorithm essentially adapts to your strengths and weaknesses, phasing out your strengths and working on your weaknesses. So the content that you see is focused more on your weaknesses and to reinforce that, and phasing out your strengths so you spend less time on the platform. The platform is specific for orthopedic surgeons as well as orthopedic residents in their residency. And it's divided into 11 subspecialties with a bonus ethics module, which comes for free. So for surgeons, surgeons use the platform. It's purchased individually, and it can be used as a studying tool for recertification and initial credentialing in the US. It can also be used for continuing medical education. But for residents, it's a bit different. It's the same platform, just what they get out of it is different. So it's a group subscription purchased by their university or hospital. So anywhere from 5 residents all the way up to 40 sometimes. And the residents use it. It's all the same content, but they use it for practice tests, for exams and performance reports. And there are a few other great things that residency programs can use the platform for that I'll cover later on in this talk. So as I said, it's the same content, the same platform. We just have surgeons and residents both using it and getting different things out of it. To drive the point home that it's adaptive, it's a pretty unique part of the platform, so I just want to cover this. Essentially, the system is learning from your knowledge, your skill, and your confidence, and it's taking into consideration how you answer the question, whether or not it's correct or incorrect. There's a confidence scale, so essentially evaluating your confidence in your answer. And then it also looks at how long it took you to answer the question. So all those features are analyzed by the algorithm, and then it essentially learns from you and determines what content you need to see subsequently. So that's the whole novelty of Clinical Classroom, is that it's adaptive and it's different for every user. So here's an example probe. I'm going to say probe or question. They're synonymous. It's a select all that apply question. And so we have a lot of different types of questions in Clinical Classroom, mostly multiple choice, but in this case, it's a select all that apply. We have matching, categorizing, fill in the blank, just to keep everyone on their toes. And then here's the confidence scale at the bottom that I mentioned. So what you would do is read the question, answer the question, and then by clicking on your confidence in your answer, you submit the question. So if you were to say that you knew it, you're confident in your answer, you expect to get it correct, as opposed to no idea, meaning that you're essentially just guessing and you don't know the answer. So this helps the system understand where you're at in terms of your confidence, and it compares it to whether or not you actually got the question correct. So let's say you selected all that apply, you were confident, and you got the majority incorrect. That shows that you're overconfident. Or if you selected things and you said no idea and you actually got it incorrect, that means that yes, you're just guessing, you haven't learned this material and you need to see this again. So the system will flag it to show you the question again. In terms of content, we're constantly adding new content to the platform about every 2 weeks. And we set a goal each year for how much content we want to add. This year is about 600 questions, and we have over 4,000 questions already in the platform. So we have the modules over here, and then each module is kind of like a class, Clinical Classroom. And essentially it has a syllabus of learning objectives here. So the learning objectives are determined by our section heads, essentially very important topics that need to be covered in order for someone to be proficient in, let's say, knee or hip. And each learning objective typically has 2 probes. And so these probes are just questions about the learning objective. And then after you answer a probe, you have access to the learning resource. It's essentially, added explanation about the question, and then also some literature for you to click on and explore as well. So these are the numbers here, but essentially it's over 4,000 questions. 4,176 to be specific. Like I said, we're constantly adding more. Sometimes we're pulling questions if we need to clarify something in there. It's a very dynamic platform. And then we have over 2,400 learning objectives. Like I said, we set a target for each year. And in the learning resource, I think it's very easy to just click and go to the relevant literature that we've added to that learning resource. Just one click and it takes you there. So if you wanted to read more about the topic, you could very easily. All of our learning objectives are reviewed and the relevant citations are added via clinical summaries. So the learning resources are very extensive. They're meant to help you and link you to other literature. And we're always adding more resources and taking into consideration your feedback. I mentioned section heads a few slides ago. These are essentially the people who are in charge of the modules. They are experts, expert surgeons. They've worked for years and years and years in their field. So JBJS has hired them to essentially create content in these modules. So they have a team of surgeons and editors behind them who create the questions, edit the questions, and respond to feedback about the questions. So we want to make sure that the questions not only are credible, but they are written by people who know what they're talking about and can help people who are confused with any questions. So there's a very high quality with our questions, and we hold ourselves to a very high standard. In terms of those who are using Clinical Classroom, we have over 3,500 users globally. We have over 50 institutions, residency programs who have used Clinical Classroom for learning. This number is constantly growing. Like I said, Clinical Classroom is pretty new, but we are definitely getting our name out there. And just generally, it's a more efficient studying tool that has very, very robust reporting. So we have a multi-institution study comparing Clinical Classroom to other systems that are very similar to Clinical Classroom. This is an annual exam that happens in the United States that all residents have to take in their residency. And the study essentially found that among online learning tools, residents who used Clinical Classroom performed the highest on their OITE score among online learning tools. So I like to say that Clinical Classroom is a lifetime learning investment because you can use it as a resident, and then you can also use it as a surgeon. The system learns from you, and then you can go through that content again and again and again as it has learned from you. You have full access to JBJS references. I'll show you later, but there's an advanced residency monitoring tool, essentially that allows programs to monitor and view activity of their residents on the platform. And in the United States, you can see you can get easy CME and SAE credits for any faculty. It looks like I went away, but I'm still here, so hopefully the camera loads again. In terms of a demo, I'm going to go through the resident side of Clinical Classroom and then the administrator side. Once again, feel free to add any questions to the Q&A section. It looks like the volume's not very good. Let me see if I can fix that. Sorry, I'm switching my screen right now. Hopefully you all can hear me. I'm going to take off this virtual background because I think that's contributing to the lag. Okay. Oh, I'm not quite sure that worked. Sorry for the delay. I feel like this stuff never goes quickly. Okay, here we go. Okay, so there are two sides to the clinical classroom. There's a side for residents and surgeons. And then, as I said earlier, there's another side for administrators. So what I'm going to go through right now is the resident surgeon side. And then after this, I'll quickly go through the administrator side. So what you're looking at here is clinical classroom when you log in as a surgeon or a resident. Essentially, we have all of our modules, as I mentioned earlier. Each module is a subspecialty of orthopedics. So we have all of these here. We also have an exam here, which I'll cover a little bit later. But essentially, when you log in, this is your dashboard, and you have a bunch of modules here under the to-do column. So what you can do is you can just click on whatever subspecialty you like to work in. I'm going to work in trauma right now, so I'm going to click into trauma. And essentially what the algorithm is going to do while it's loading is it'll collect a bunch of questions that it wants me to go through so that I can learn whether or not I'm strong or weak at it. So I've actually worked in this, this module a bit, so it's probably learned enough about me to know what I need to see and what I don't need to see anymore. But each module has about 400 questions in it, and it's likely that I will not see all 400 questions as the system determines what content I'm strong in and what content I'm weak at. So I'll probably see maybe about 300 out of the 400 questions, but you have access to all of the questions, which I'll cover right after this. So here's a multiple choice question. It's pretty simple. You read the question. You can select whatever answer choice you believe is correct. I'm just guessing, so I'm going to say I have no idea. It tells me the correct answer, gives an explanation about it, why it's correct, my answer, why it was incorrect, and then the two other wrong answer choices. As I mentioned, you can click here, learn more here. And typically it gives you a few paragraphs that are an additional explanation about the learning objective, which is up here. If that's not sufficient and you want to read more about it, you can click next. And you can click on these articles that we've provided here, and they will take you directly to the literature. If it's a JBJS published article, you'll get the full text. If not, you'll be taken to PubMed, and then hopefully through your institution or your organization, you have free access to PubMed to read the full text. There's also a feature here called Challenge Us. This is how we get feedback. So let's say there's something confusing about the question, or you thought you got it correct and you didn't. You can write to the section heads, the people who make the questions, and sort of tell us why you think we made a mistake or why something was confusing, or if you need clarification, and it goes straight to them. So there's a direct link between you as a user and the people making the questions. One other thing before I move on I didn't talk about yet is called the self-assessment panel. This is a way to let the system know where you are in terms of your knowledge and competence. So let's say, for example, you're a resident who's starting a trauma rotation for the first time. I probably wouldn't say that I'm proficient in trauma. I'd probably say that I was novice or advanced beginner. And this just lets the system know your proficiency and how to tailor the experience to your career level or your knowledge level. So if I were a novice, I would see a lot of these learning objectives initially to help supplement my knowledge of the subspecialty, as opposed to if I were an expert, this would show only questions because I don't really need to see any of those learning objectives automatically. You can always click on the learning objectives, but they just won't pop up automatically. So I usually set myself to proficient, even though I'm not proficient in orthopedics. But it's a happy medium between the learning objectives showing up and the questions. I'm just going to go through one other quick question here, just to drive the point home. I'm going to click on the correct answer. I usually guess. This is a great example where I got it correct, but I guessed. So it says correct, however, you are not confident. So the system also identifies when you are guessing and you're not confident. So it's going to flag this, and I will see this question again for sure. So I'm going to go back to the dashboard over here. What I just showed you is the same experience for all of the modules. It's just a matter of going through the questions, and as you go through the questions, your progress for that module increases, and the estimated time to completion, the 7 hours and 34 minutes here, will go down. So, and if you want to find your total, it's just over here up to the right. One other thing that I want to cover is if you go to the menu, you can go to the library. And this is where all of our content is. So like I said, if you see 300 out of the 400 questions and the module says you are done and you want to go through the other content, you can do so in the library. It's essentially all the modules deconstructed. So we have hip here. I can collapse this. And then as I collapse it, you can see all of the different topics within hip. And in this case, let's say I want to work on non-arthroplasty hip procedures. I can see the learning objectives here. The slide, the blue box means the learning resource. So I can click on this. I can read more about the learning objective. In this case, it has a chart. And I can also click on the literature. The green boxes are the questions or the probes. This one's a multiple choice question, MCQ. I can click on this, and I can also take the questions in here. The only difference is there's no confidence scale. You just say, okay, since you are picking and choosing, what you want to work in, the algorithm is not active. So this is a great tool if you're looking for something specific. You can search for something, or if you just want to go through the content without the algorithm. But I definitely recommend going through the dashboard and going through the modules, as I showed you earlier, since the system is able to learn from you that way. We have some reports as well. These reports essentially is a digest of the data that the algorithm is gathering on you. So as you spend some time in Clinical Classroom, you can see in each module what your progress is, your total time spent, your time left, and you can also, based on your confidence and if you're getting questions correct, you can see your average percentages in awareness and correctness. And you can also scroll down. This is mostly for residents, but if you're interested to see where you're struggling most, you can calculate your most challenging learning objectives report. I'm going to go back to the dashboard. This is pretty much it for this side. Also for residents, you can create practice sets, which is very helpful. I think that's pretty self-explanatory. When you finish a module, it goes into the refresh column over here. You can click on it and you can go through that content again and again and again if you want to. I will say that one thing I always forget to mention is that Clinical Classroom can be used on a computer, a tablet, and your mobile device. So you can go through questions, if you're, in the hospital, just on your phone, or if you want to go back to your office or home, you can work on it on your computer as well. So it's responsive on many platforms. I'm going to go through the Q&A section to see if I have any questions here. Feel free to ask some questions. The time indication is the estimated time to completion. So it hovers around 7 hours. Usually it takes about 4 or 5 hours to complete a module. But that is what this means. If you want to see how long you've spent, once again, you can go to the reports, and one of the reports will let you know how long you spent in the module so far. Is there any specific app for JBJS Clinical Classroom? There's no app that you download for Clinical Classroom. If you're using your computer, you just go to the link that will be provided to you. If it's on your phone, you would just go into Google Chrome, which is the preferred browser for the platform, and you use the same link, and you just go on your phone using the browser, and then once you're logged in for the first time, you'll be prompted to create what's called an app shortcut. So essentially, you're creating a shortcut on your home screen that will take you directly to Clinical Classroom in the browser. So kind of like an app, but you're actually not downloading anything from the App Store if you're using an iPhone. Those are the 2 questions we had there. Feel free to ask some more questions about this side. In the meantime, I'm going to switch over and go to Educator. Educator is the admin side of Clinical Classroom. It's sort of the back side of Clinical Classroom. What I just showed you here is what we call Learner. It's for those who are trying to learn. And then Educator is for those who are trying to educate. So an Educator, essentially what you have is classes of individuals. This is mainly for those who are interested in the residency side of Clinical Classroom. Also with your organization, you could have, let's say you have about 20 surgeons who want to use the platform. We would also consider that an institution or an organization. So you could group those 20 individuals into a class, and you can click on this class here. And essentially what you can see is all of the activity of those individuals in Clinical Classroom. So I'll click on Learners here. And just by clicking on this tab, you can see we have 4 active learners. We have 3 inactive learners, 1 invited and 1 retired. So active means that they have logged in the past 30 days, the past month. Inactive means that they have logged in, but just not within the past month. Invited means that they have not logged in yet. And retired means that their access is expired. So this is a good way of seeing what learners are in your class. You can see all the names and such here, and you can see their status, so their activity. You can go to assignments over here. We have different types of assignments. The ones that are only really relevant for you are exams. By default, you're given a learning content package or a learning assignment that essentially gives the residents the ability to look at Clinical Classroom modules. So that's given by default. Another default assignment is a practice set. This gives them the ability to create practice sets. So learning and practice set assignments are given by default. And then exams are things that you can create yourself if you want to. If you want to do pre and post rotation exams, if you want to give an exam to a specific resident or a group of residents, you can make those exams and assign those exams in Educator here. The other important feature of Educator here is you can go to Analytics all the way to the right. And we have a lot of reports that you can use to monitor your residents. So we have performance summary, learning progress, class overview. We have an exams one where you can see how everyone is doing on the exams. I like to use performance summary. That gives the best overall glimpse of how your program or organization is doing. It might take a little while to load, but essentially the platform is useful in that it can give you reports that you can download. This is a test account, so it's not heavily used, but you can see each learner and their progress in each module and their total time spent in each module. You can look at performance summary. I'll calculate some of these. You can look at the class's most challenging learning objectives to see where they've struggled. You can see between two dates how everyone is doing, how their time is spent daily. You can see their overall progress, their total time spent, how many questions they've gone through, when they last accessed it. So you get a lot of data on how the people in this class are using Clinical Classroom, if they are using Clinical Classroom too. So just as a recap, Educator is sort of the backside. It's the administrator side of Clinical Classroom that lets program leaders or organization leadership evaluate what members are using Clinical Classroom, how they're using Clinical Classroom, and any of their performance and activity. So please let me know if you have any questions. I'll go through the Q&A here.
Yeah, we have a couple of questions in the chat as well. So one of the questions is, what are the types of learning resources JBJS Clinical Classroom offers?
So we have a lot of resources, like I mentioned, with each question. You can go through the questions, and then we have the learning resources there and the literature and such. But I mean, JBJS offers a lot of other types of CME resources. We're first and foremost a journal, so we have a lot of journals that we publish as well that you'll have access to. Yeah, I'm not quite sure what resources you're asking specifically about, but there's a lot that you can do with Clinical Classroom, as well as our website.
Aiden, if I could jump in, I think perhaps the questioner is trying to understand whether there are other resources that are not from JBJS in the system, and the answer to that is most definitely yes. Some of the resources come from American Academy of Orthopedic Surgeons guidelines. Some of them are linked to PubMed for articles that are not out of JBJS. In other words, it's a broad range of literature, not just JBJS learning resources.
We have another question about monthly subscription system. Amit, do you want to answer this question?
Yes. We don't have the option of monthly subscriptions. We have annual subscription for individuals as well as institutions, and the rates for individual and subscribers from India is 14,999 plus taxes. For personal subscription, that's an annual. They'll get access to all the 10 modules plus bonus module for a period of 1 year. And for institutions, it is a seat-based model where we will first take into account the number of users, and then we will prepare a quote and send it to the head of the department of the library interested in subscribing to the product.
So I've gone through Learner and Educator. So please let me know if you have any questions about that.
Yeah, there's another question. Are there any videos?
So we don't have any videos in the platform, but the journal does publish a lot of videos on our website, and some of the literature that we link to also has videos themselves. So no, we don't have any videos in the platform, but some of the literature that we link to does have videos.
The last question which I could read here is how many practice tests we can create in one account? Is there any limit on number of practice tests?
You can create probably as many practice tests as you would like to. I've created about 10 practice tests, so I know that the minimum is probably 10. I've never tested the maximum. So you could go maybe to like 100 if you like. It's whatever you want.
As long as the subscription is active, the platform offers you to create as many practice tests as you.
Correct.
I think we can go ahead. Aiden, are you done with the presentation?
Yeah, I finished the PowerPoint presentation and I went through the two platforms.
Done. So, if you have any questions, you can still ask, and we'll try to take these questions in the end. Okay. So thank you so much, Aiden, and for giving us a very detailed presentation on JBJS Clinical Classroom. Now I would invite Dr. Marc Swiontkowski to start his presentation. Before he starts his presentation, I would like to introduce Dr. Marc Swiontkowski to all the attendees and the panelists in today's seminar. Dr. Marc Swiontkowski doesn't need any introduction because he has been into the orthopedic surgery field for long years, and he has been very popularly known as the editor-in-chief of one of the oldest journal in orthopedic surgery, which is Journal of Bone and Joint Surgery. He was he is also part of board of directors Mid-America Orthopedic Association, and he was the past president of American Orthopedic Association and Orthopedic Trauma Association. So he's also Director Emeritus of American Board of Orthopedic Surgery and American Board of Medical Specialties. And today he is one of the keynote speakers who will be presenting and giving a short lecture and seminar on intertrochanteric fractures. And he will also be taking questions from the audience. Just give me a second. Dr. Marc, I will give you the Dr. Marc, you can share your screen now. You can start your presentation.
Can you see the screen?
Yes, you can
Okay.
see the tile. Yeah, thanks.
Okay, and you can hear me well?
Yes, it's very
Okay.
crystal clear. Can you move the slides so that we can check if the slides are moving?
Yep.
Yeah, perfect, perfect.
Okay, good.
Thank you.
So thank you very much for that kind introduction. If any of you were online, the last meetings like this that we had, we discussed femoral neck fractures, and so we thought that it would be of value to complete a review of all proximal femur fractures by moving to the intertrochanteric hip fracture location. So here's the outline of my presentation. We're going to talk about classification and how the concept of stability is involved. And we will, in that discussion, cover the differences between a stable and unstable intertrochanteric hip fracture, as well as subtrochanteric fractures. Briefly about non-surgical treatment, a lot of time on implant selection. We'll talk about some data from the American Board of Orthopedic Surgery, as well as cover some meta-analyses on implant selection. So here is the Orthopedic Trauma Association and AO classification. You can see A1, A2, A3. And A1 is the stable classification, with A1.1 primarily being the base of the neck of the femur, the others being variants of the stable construct. And A2 is the question where stability is along a spectrum. And I would point out to you the thickness of the greater trochanteric fragment as being very, very critical. It's often called the lateral wall, and if that section of the intact femur gets very thin, it will create an unstable pattern. And then, of course, the A3, which are all unstable, is the subtrochanteric variation. So there are multiple types of implants that can be used to fix the proximal femur fracture. Both the short and long intramedullary nail, most, if not all, manufacturers have these. The sliding hip screw or compression hip screw, which again, all manufacturers have them. And then there's a locking plate in the proximal femur, which I would say does not have widespread indications and is for special, highly comminuted variations of base of the neck fracture. But we'll go through these choices in detail. So I think the decision making for the stable fracture is very straightforward. And I will show you a lot of data that supports the notion that the sliding hip screw should be the standard of care. It would also be pertinent to point out that 2 screws in the side plate are enough. There's not really much advantage to adding a longer side plate unless it's really, really highly comminuted and with the trochanteric extension plate, which I'll cover. And the A3 unstable, it's very, very clear that the intramedullary implant is the best. For a subtrochanteric fracture, I would recommend the long intramedullary nail. If you have an unstable A2, the short intramedullary nail is appropriate. And then I show again a line drawing of a complicated fracture that you might use the locking plate, but this is one where I would hold it in reserve for very, very comminuted fractures, primarily in younger patients with very good bone density. The locking plate for osteoporotic bone in general is not a great idea, and we can discuss that in the Q&A if you wish. So here is the section of the classification where you can go either way. And you can use a sliding hip screw, but particularly the A2.2, where you see that lateral wall or the intact greater trochanteric fragment is very thin. It's even thinner in the 0.3. You should use this trochanteric stabilization plate, which basically limits the amount of sliding that can occur. A good choice also is the long or short intramedullary nail for these unstable patterns. And then I just covered the lock plate, which should be used rarely. One must always remember that in an older population, I would say greater than 60, that you should consider a comprehensive osteoporosis evaluation, including a DEXA scan, if it's available in the postoperative period, with appropriate treatment with pharmacologic intervention to manage the osteoporosis. So radiographs are where we always start with proximal femur fractures with an AP and a cross-table lateral. Perhaps you have not used in the past. I would suggest that you consider a traction view, simply pulling with longitudinal force on the limb and obtaining an AP X-ray. It's very, very helpful for you to understand the fracture pattern and the degree of instability. So if you have some doubts about the thickness of the lateral wall or other components of the fracture, this is very, very useful, particularly if you don't have access to a CT scan to evaluate the fracture pattern. So what is the concept of this stability? It's basically the ability of the reduced fracture to support physiologic loading. And it not only relates to the number of fragments, but the fracture orientation as well. The more vertical the main fracture plane orientation, the more unstable the fracture. So here's a couple of examples. The one on the left is a very stable base of the neck, A1 fracture pattern, and the one on the right is an A2.3, which is clearly unstable. And then there is a variation of the A3 that you see. Some of those particularly, this is 3 different x-rays, of course. The one in the center is particularly unstable because you see the subtrochanteric extension and a highly comminuted fracture plane that extends into the starting point for an intramedullary nail. And I'm going to talk about that at the very end, about how you have to take great care not to let the main intramedullary starting point fall into the fracture plane. So what's available to increase the stability of the bone implant interface in the face of osteoporosis? You can use methyl methacrylate. That's point 1, where you can increase the load to failure by placing cement in the channel of the compression screw component. You can also use some calcium phosphate type cements like Norian, which is made by, or marketed rather, by Synthes, and you can see increased load to failure there as demonstrated in a couple of publications. But the clinical factors, whether you have these these alternatives available, and the cost of them has to be considered. And you can see a reference about hydroxyapatite coated screws, which are more expensive and add limited benefit. So there are adjuncts, but one should consider whether they're available and their expense. So what are the factors that influence construct strength? The bone quality we've addressed earlier, the fracture planes we've addressed earlier, but the main thing that we can control as surgeons is the quality of the reduction, the placement of the implant, and the selection of the implant. These are things that we need to get right to prevent a disaster like you're seeing in the image on the right side, with a very poor placement of the central compression screw. So fracture reduction is very critical. In the past, in the older literature, there were suggestions that one should use a displacement osteotomy to increase the stability. That's probably not necessary or even advisable in modern day. The reduction is the thing that you must concentrate on. And you have to have well-oriented reduction with appropriate placement of the implants, which I'm going to show you here. One major advance in intertrochanteric hip fracture research was from Mike Baumgartner from Yale, who came up with the concept of tip apex distance. It is the distance between the tip of a compression screw on either a sliding hip screw or an intramedullary screw and the articular surface. The 2 radiographs which I'm showing you are demonstrative of a very poor placement of a hip screw in both planes. This will lead to predictable failure. So what you do is you add the distance between the tip of the implant and the center of the femoral head on both planes, and that gets you the total of them gets you the tip apex distance. And here's a chart from Mike Baumgartner's seminal publication in 1995 in JBJS, showing that if you're placing the screw with a tip apex difference of greater than 24 millimeters, you have a very high risk of cutout, which is listed in the red. And you can see that the greater the tip apex distance beyond 24, the higher the risk of cutout, with very high percentages at greater than 30 millimeters of tip apex distance. So this is a very, very important concept. This is showing the data in a different graphical presentation, showing increasing tip apex distance relating to screw cutout. And of course, the worse the bone density, the higher this risk is increased. So the screw has to be dead center on both views. I'm showing you an image of a lateral view, and very, very deep into the femoral head where the subchondral bone is the most dense. It allows for the maximum slide of the implant, the maximum stability of the post-fixation construct, and allows for the reduction, which hopefully is essentially anatomic, to bear the load of hip flexion and increasing weight bearing. So let's talk about that transition group, the A2 group. And I'm going to show you a series of meta-analyses. You'll recall that meta-analyses are pooled data from multiple randomized controlled trials. Here is a case of short intramedullary nails, specifically the gamma nail, versus a sliding hip screw. And it was the first meta-analysis published in 1996. And you can see that the analysis favored the use of compression hip screw because of issues with fracture extension, of missed locking bolts, etc. And it was clear from that point that that the intramedullary hip screw required more experience in order to avoid these complications. So this meta-analysis was updated some 9 years later, again confirming in 28 randomized controlled trials that the gamma nail was inferior, and it offered no advantage with continued intraoperative fracture increases. It was most recently updated by Dr. Bandari, and what you can see is that as the orthopedic community worldwide has gained experience, that the femoral shaft risk with misplacement of the locking bolts has basically disappeared. So there's no increased risk with nails, but there are issues with expense of the implant, which we will address. So there's also been some consideration of the systematic effects on the lungs by placing an intramedullary device versus a sliding hip screw. This is a publication some 11 years ago, an injury with a randomized controlled trial in 120 patients, sliding hip screw versus a short intramedullary nail. And there was no difference between blood loss, operative time, or fluoroscopic time. But the mini mental status exam and pulmonary function were worse in intramedullary nailing. So with a particularly sick patient where you could use a sliding hip screw versus a short IM nail, you might want to consider the sliding hip screw. This is a different study which compared the long gamma nail versus a sliding hip screw in 210 patients. This was not a randomized controlled trial. And this was the A2 fracture classification, which we addressed earlier, and showed no difference. So it is something to consider in a very ill patient, perhaps within your patients that have pulmonary compromise or congestive heart failure prior to their hip fracture. So it's pretty clear that there's a mechanical advantage with an intramedullary nail because your moment arm is moved and the stress on the implant is much less. The question is, when should this be employed? I'm going to address now the issue of the lateral wall that I spoke about during the classification section. And it is the thickness of that lateral wall, the distance between where the barrel of the side plate starts and the main fracture plane. So if that gets very, very thin, there's increased risk of dramatic sliding and failure of the implant. So you can address this with the trochanteric extension plate. It has been covered in several cohort studies. You see them listed on the bottom of the left. It basically limits the amount of slide when you have a very thin lateral wall. And it simply snaps over the plate, side plate, and is fixed with 2 of the screws that go through the side plate. So it can be applied once the sliding hip screw is placed and you've slid the side plate over, then you snap this on to the side plate and then place your side plate screws. The patient setup, I think most people on the call are familiar with the patient in the supine position on a fracture table if available. You need clear AP and lateral imaging to be able to judge your reduction and make sure that the neck shaft angle is restored or is in slight valgus so that you can position your guide pin center and deep within the femoral head. What about postoperative management? We believe that the literature supports that patients should be allowed to bear weight as tolerated. Elderly patients with balance issues are not going to be able to limit weight bearing, and they're going to self-regulate their force on the limb, and does not appear to be any increased rate of failure. We would recommend 2 follow-up post-op x-rays at 6 and 12 weeks. Now, if you're in a situation where you have very limited access to implants, it's important not to forget that it is possible to use an external fixator. And I'm just pointing out a randomized trial, a small trial, using external fixation versus a sliding hip screw. And if you're in a resource limited situation, this can be used, but again, you do need a fluoroscope to place these pins optimally. I'm showing you a suggested orientation of the pins on the left diagram. And in this series, in this trial of 40 patients, there was a faster operations with external fixation, fewer transfusions, less postoperative pain, and there was no major difficulties with pin tract infection, although that is clearly something you have to deal with, particularly in a heavier patient. And in this particular trial, they kept the external fixators on a minimum of 6 weeks up to 12 weeks. So they can be difficult to manage these patients in terms of caring for the pin tract, but it is something you can do. So implants have different traits, and we have to choose them wisely. They have to be placed correctly. And again, I'm going to refer to this tip apex distance, regardless of whether you're talking about a sliding hip screw or a short intramedullary nail. It's extremely important to get within 5 millimeters of the articular surface on both views, if at all possible. And then also in the lower right-hand corner, what we're showing is the correct starting point on the right side, and the one on the right hand of the right hand image is showing a starting point that is oriented too posteriorly and can lead to problems with the tip against the anterior cortex. So just a few cases to show you. This is a stable pattern in a patient with a contralateral total hip fixed with a sliding hip screw. With a base of the neck fracture, I tend to recommend adding the second cannulated screw. I generally put that in first after placing the guide wire for the sliding hip screw. And this patient had excellent result. This one is a fracture with a shorter lateral wall. And here with a tip apex distance of less than 25, very central and deep placement. The patient did well. This is a more unstable A2 variant. Here's the reduction films on fluoroscopy showing slight valgus. And here we added a trochanteric extension plate. And you can see that there was a shortening that occurred. I'll just bounce back and forth. Here's the intraoperative, and here's the postoperative. You can see some shortening did occur, about 1 centimeter, but the overall fracture healing occurred with acceptable functional outcome. Now I'm going to show you a couple of errors very quickly before getting the question and answer. This is a very large tip apex distance. where you can, in a base of the neck fracture, you can see that it did not heal, leading to a non-union because of the very short working length. And we salvaged this by curating, bone grafting, and placing 4 screws. And that went on to heal. Here's the healed view. Here's the immediate postoperative view. Here's the healed view, and that patient went on to do well. One last example is a very poor placement of the screw. You can see it's short and it is not well placed. Here it is, it's posterior, you can see. And here it's cut out of the posterior aspect of the femoral neck. This is the way we salvage this with a 95-degree condylar plate, the preoperative plan. And there is we grafted the channel of the device and fixed it with a 95-degree device, and that patient went on to heal. This is the last point. This is an example where the surgeon did not understand that the starting point for the long intramedullary nail was through the fracture plane. And as you can see, the nail cut out through the back of the femur through the fracture plane. It's very important to understand where that starting point is. In this case, it was way too posterior and the nail cut out. Just some graphs from the American Board of Orthopedic Surgery data showing that the use of sliding hip screws has gone practically to zero over time in the United States. And I'm quite convinced that this is an error. The sliding hip screw costs about 1/3 of what an intramedullary nail does. And it's been shown that the blood loss arguments and the operating time arguments and the fluoroscopy time arguments are not accurate. And I would advocate using a sliding hip screw for the stable, certainly for the stable A1 patterns and for the A2.1 patterns. This is just showing that the complication rates were higher with the intramedullary nail. The last slide is geographic variation for the use of sliding hip screws versus intramedullary nails. This was, I was a co-author on this. This was published 13 years ago. We looked at the Medicare files, which is our national insurance for our elderly population. And we showed that the intramedullary nail use increased substantially over the time frame of this study, and that there's high regional variation, and that it's primarily around academic centers. So the conclusion is that intramedullary nail is clearly indicated for reverse oblique and subtrochanteric fractures. I would use the long intramedullary nail for that, and it is an alternate for the A2.2 and 0.3, where you can use the short device, but sliding hip screws is generally indicated for stable patterns, and I would encourage you to continue to use those. So let's see now, Amit, if I can see the questions.
Yeah, I don't know if this is a question or a comment from Dr. S. Senthil Sailesh. He writes a trick for perfect entry point for proximal femoral nail.
I'm sorry, the preferred entry point for a proximal femoral nail. Okay, yes. So that would be in line with the neck of the femur on the lateral view. So it is in the upslope where the femoral neck is translating to the trochanter. So on the upslope, not on the tip of the trochanter, just inside the tip of the trochanter, in line with the femoral neck on the lateral view.
We have just one question, and to all the participants, we are posting the link where you can post your questions. It will be very easy for us. Click that link and write your question. Share your question with Dr. Marc. If you have any question, you can use the chat. Yeah, from Dr. Manoj Prabhakar is asking DCS or DHS, which can be preferred for stable fractures?
So DCS, my understanding of that term, dynamic compression screw, is a 95-degree compression screw, whereas the DHS is a 130 to 140-degree device. So it would be the DHS with the higher angle. DCS, the 95-degree, would not be appropriate for a proximal femur in general.
We have some questions regarding the quiz which we are going to share with the audience. So as of now, I don't see any questions on the Q&A link. So in the meantime, before we get any questions, Dr. Marc, I would want you to share your comments or feedback regarding the JBJS Clinical Classroom. Do you have any comments to share with the audience about JBJS Clinical Classroom? Since you are also an orthopedic surgeon, and you can share your feedback.
Here's, of course, I'm biased. I'm very biased because I was in place as the editor when New England Journal of Medicine approached us at JBJS about making the first non-primary care application of this advanced learning platform. And we developed the process by which we built the platform by getting mid-career academic experts as section heads to write learning objectives and to review those learning objectives twice per year. And once those learning objectives are constructed, we ask them to have several layers of depth of learning. So, for example, if you have the problem of acetabular fractures, the basic level would be identifying an acetabular fracture. The more complicated learning objective would be to define the type of acetabular fracture pattern. And then the third level down would be issues like what is the correct surgical approach for an individual fracture pattern. So each learning objective has levels of depth so that interacting with the platform is appropriate for residents all the way to very, very experienced subspecialty surgeons. It was difficult at first to train academic orthopedic surgeons to write learning objectives because all of us had grown up in the multiple choice question format and weren't used to thinking about adult learning in this way. But we've been able to streamline the ability to educate very experienced people how to write these objectives, and then they recruit younger surgeons to provide the knowledge probes or questions at these various levels. And one of the great things, I'm not sure whether Aidan covered this, is for every response that you give, you can offer a challenge saying that to the author of the question that this is not correct, or the options for correct answers are missing something. So the platform is undergoing continuous improvement with feedback from individuals who interact with the platform. So I'm absolutely convinced that this is the way forward for knowledge acquisition for younger surgeons and knowledge maintenance for experienced surgeons throughout their career. The platform gets better as each month goes by because of this feedback and continuous review of the learning objectives. And my, again, highly biased view is the era of the multiple choice question, which doesn't undergo much psychometric testing or anything. Those days are numbered. I think this is the way forward in medicine in general. is adaptive learning platforms, which are continuously evaluated and improved.
Thank you, Dr. Marc. We have questions. I have just seen a question from. Yeah, this question is from Dr. Manoj Prabhakar. He is writing intertrochanteric with subtrochanteric extension. Can DHS be used?
No, that is a very, very highly unstable situation where it would be not recommended unless you absolutely don't have a long intramedullary device. The working length issue is very critical with a subtrochanteric extension. So you need that better biomechanical advantage of the intramedullary device in order to prevent catastrophic failure. So I would say no to that question.
Yeah, the next question is from Dr. Senthil Sailesh. He writes, if there is a lateral blowout during nailing, what will be your bailout option?
Sorry, can you state that question again, please?
Yeah, if there is a lateral blowout during nailing, what will be your bailout option?
Okay. Lateral blowout during nailing, the bailout option. Okay. I would first consider cerclage wiring around the fragment. That would be option number one. On several occasions, I have had to salvage this situation where the surgeon placed the starting point way too lateral and created a very thin lateral wall that broke through. And what I have done in that circumstance is I've taken an allograft piece of bone and again cerclaged it to create an augmented lateral wall to contain the nail. I don't think you can convert that to a sliding hip screw because the mechanical issues are too great with no lateral wall at all. So I would consider an allograft if you can't cerclage what's left of the remaining lateral wall there.
The next question is for us. Dr. Asadi from India is asking, do we get certificate of attendance for this seminar? Yes, we will be sending you a link where to submit your name for receiving the certificate after this session. So we'll be soon sharing the link. Submit your name for the certificate. Next question is from Dr. Akhil, who is a physiotherapist. So he is writing, so after DHS post-op, after how many days can we make the patient mobile?
Immediately. I don't think there needs to be a waiting period. I would get the patient up as soon as possible.
Okay. Next question is from Mr. Jay, Dr. Jay. Do you avoid mobilizing? Question has. Yeah. Do you avoid mobilizing PT in unstable fractures? PT stands for physiotherapy, yeah, right?
Yes, I would advise mobilizing the patient. I think there's less risk in terms of the pneumonia, other issues with prolonged bed rest. So I would mobilize. I would take the chance to mobilize the patient to basically save the life.
Next question is from Dr. Manoj Prabhakar regarding distal locking in IM nails. Regarding distal locking in IM nails, where only dynamic can be preferred. I don't know if you are able to understand this question.
I think the questioner is asking when the hole in the tip of the nail is only oval, meaning it's not a round hole, so you don't get complete stability with the screw within the nail, where you would place the screw. And the answer to that is at the top of the hole, the proximal aspect of the hole, which is going to preserve the neck shaft angle fixation proximally. I think that's what the questioner is asking.
We have a few questions on the link. Sharing my screen so that you can see the questions on my screen.
Okay, good.
Just give me a second. Yeah, can you read the questions, Dr. Mark?
Yes, I can see.
First question is, could you explain assessment of fracture stability?
Yeah. Okay, so as I showed, it's the A2 classification, that is the transition from unstable, from stable to unstable. And the lateral wall, if it is less than 5 to 8 millimeters in thickness, if it's intact, that still, I would say, is an unstable pattern. The posteromedial comminution is also an indicator of instability. And if you see a large fragment involving the lesser trochanter, not a small one, that would point me towards predicting that to be unstable. So lateral wall thickness less than 5 to 8 millimeters with a large posteromedial fragment, that's unstable. So that would be the A2.2, A2.3. The next classification is about classification. It is the OTA AO classification, which I alluded to in the presentation, where A1 is stable, A3 is unstable, and A2.1 is stable, A2.2 and 0.3 is unstable. Subtrochanteric fractures, which is preferred, a proximal femoral nail or an intramedullary nail in reconstruction mode. I think either one is acceptable, depending on what you have available in your treatment facility. In general, I prefer the intramedullary nail in reconstruction mode with 2 implants up into the neck and shaft, but I have both variations available. I don't think it matters stability-wise with either approach, with either device rather. What's most critical is the starting point of the nail, which I alluded to before.
We have some more questions. We have some more questions here. Q&A section. Dr. John Casey is asking reduction tips, please.
Reduction tips. Well, it's the positioning of the patient, and when you're looking on the lateral view, if the shaft is translated posteriorly, what you can do is you can put a crutch underneath the shaft of the thigh on the fracture table to lift it anteriorly. That's a useful trick. That's if you're using supine nailing. For me, when it's a subtrochanteric fracture, I use the lateral position on the fracture table because I think it's easier to get the reduction than with the patient supine. So it takes a little more time to put the patient in the lateral position on the fracture table, but for subtroch fractures, I think it results in the better reduction, and it's easier.
Next question from Dr. Senthil Sailesh is distal screw. When will you use dynamic or static locking?
I pretty much always use static locking for subtroch fractures, and you can always remove the screw if it's a concern regarding healing. I would wait 3 months before I would consider removing a static lock, but I always use static locking for either a short or long intramedullary device.
Next question is from Dr. M. Sarvanan. He's asking difference between intramedullary femur nail and PFN and PFNA and gamma name based on implant design, entry point, and indications?
Well, the devices are all different. They have slightly different angles at the upper end, and you have to understand how much the angle is at the upper bend, where it transitions from the broader proximal end into the smaller distal component. And the more angle that's there, beyond about 5 degrees, the more you have to move the starting point laterally. So you just have to look at the device. Most of the time you can have access to a technique manual that's available online by the manufacturer's guidelines, and take a look at where they recommend the starting point. In general though, most of the time the errors I see with any of those devices are placing the starting point too posterior or too lateral. You have to remember that when you're looking at the greater trochanter from the side view, that the neck of the femur is in the anterior half. So it's very easy to make the starting point too posterior.
Yeah, we'll take this last question from Dr. Manoj Pravakar. In case with surface replacement arthroplasty of hip presenting with A1, A2 tie, preferred implant of choice?
Okay, say that one again, please, Emmett.
In cases with surface replacement arthroplasty of hip presenting with A1 and A2 tie, which is the preferred implant of choice?
So an intertrochanteric hip fracture with a surface replacement. I would think you would just follow the guidelines of addressing the stability. If it's a stable pattern, I think you use a sliding hip screw and get it as central and as close to the surface replacement as you can, without, of course, pushing against the metal shell of the proximal femur. If it's an unstable pattern, again, I think it's appropriate to use an intramedullary device with the correct starting point. And again, you have to not use too long a device. You have to get as close to the metal shell covering the femoral head as you're comfortable. Try to leave probably 5 millimeters. I've actually never seen that problem, so I'm just basing my recommendations based on what seems reasonable. Oh, somebody's listed a question here. What is the dynamic hole for? Well, the dynamic hole is when the surgeon believes that their proximal fixation is perfect, the placement of the device is perfect, and they want the fracture surfaces to compress with weight bearing. So because we're not opening the fracture site, I don't know that we have a situation where the reduction is perfect. So that's why I use static locking because I don't want it to have it compress and lose the neck shaft angle. Okay, what should be the opposite? Should it be flexed to 35 or 460 degrees to achieve better reduction? So there's two ways to treat the opposite leg. One is to abduct it as far as possible. If the patient has any arthritis in the hip, that can be difficult. And then you can flex it up with the leg holder. And I would say it should be at least 60 degrees to get the optimum lateral view. It's not difficult to align with the hip flexed up on the opposite side. And you need to have as much hip flexion as you can get for the lateral view. In general, I prefer to abduct the hip, the intact hip, whenever possible. I think it's just easier for the patient and anesthetists and everyone.
Yeah. Can I ask one question, Dr. Marc?
Sure.
Yeah, this is regarding the clinical classroom, the content of clinical classroom. How far this content on clinical classroom is relevant to other parts of the world, like especially India?
Oh, well, I've been to India many, many times, and I know that there are surgeons that are practicing in environments where they don't have a lot of resources and are doing the best with limited access to technology, etc. But there's also centers where there's no difference between surgical care going on in India with that going on in North America. So I think the content is extremely relevant for the super specialized people all the way down to the surgeons who are working in relatively austere environments.
Thank you. Thank you. Thank you so much. Thank you, Dr. Mark, for your time and for presenting and taking the questions patiently. And we hope everyone in this seminar have found the presentations from Aidan and Dr. Mark very useful, and you have enjoyed your both the sessions. Now I will ask my colleague Dinesh to share the link. This link is basically gives you access to all the links, and also gives you access to the next part of the session, which is clinical classroom challenge. This is a short quiz which we have designed for you, and this is the second link which you have to basically click in order to register for the quiz. Yeah. So in this sheet, you will find several links, and the first link is feedback and e-certificate registration. You can click this link, and this access to this link is will be active, and you can fill the feedback of today's session and share your feedback with us. And the name which you will be entering on this form will also be printed on the certificate. The next link on this sheet is clinical classroom challenge-based registration. So once you click this link, it will take you to the registration page where you will have to enter the email address and enter the password, because it will ask you to enter the password in case if you have the account already registered on JBJS Clinical Classroom. Basically, you will have to first register JBJS Clinical Classroom in order to access it. I'm trying to show you the steps how to create your account and access the quiz. It will ask you to enter your name, email address. Your account will be created, but you will have to confirm it by clicking the link, confirm email, to set your password. So I'm going to check my inbox and see if I have received the email to confirm my registration. It is so this is the confirmation email. This is the next step where you will have to click this link, confirm email link. And once you confirm, you will be asked to set up the password for your account. So I'm going to set the password. It's about roughly 2 to 3 minutes to set up the account and get access to the account has been created and dashboard is loading. And I should be able to see the quiz. Yeah. So you will see this module on exam on Intertrochanteric Fractures exam. And once you log in and click this module, you will be able to start the quiz. I hope this was pretty simple and very straightforward, and you will be able to set up your account and participate in the quiz. So there are 16 questions in this exam, and you will only get one chance to attempt this exam. Aiden, is there a due date for this exam? Can you please confirm?
Hey, Amit. No, there is no due date.
Okay, fine. So what we will be doing is that we'll be announcing the results on 15th of July. So you have time till to take this test till 15th, before 15th. On 15th, we will be announcing the results, and we will be announcing the results via email. And we will recommend you to join the WhatsApp group on this page, because it will be very easier for us to communicate the results to you. On this page, there is a WhatsApp group link on which we will be updating the results of the quiz as well. So there are several other links on this page, like you can also sign up for a free trial to JBJS by clicking on this link and submitting your name, registering for this trial. And you have links to our social media page and a link to sign up to receive the newsletters from Thieme Publishers, and link to access browse our books, journals, and online database, which is Medone Spine and JBJS Clinical Classroom. And the last link is the contact us link. I would request my colleague Dinesh to share the link again with all the participants. We will be sending out this link via email also tomorrow morning, in case if you are not able to access it now. Just check if there are any questions regarding the quiz or certificate. Dr. Rajiv, the link has been shared again by Dinesh with everyone. I hope you are able to see the link in the chat. that's it from my side. Yeah, great. So that's it. And on behalf of Thieme Publishers, I would like to thank Dr. Marc Swiontkowski for his time and to attend this seminar with us. And also thank Eden Smith for giving us the presentation and joining us this webinar. And last but not least, I would want to thank all the participants and attendees attending this seminar. And if you have any questions, please feel free to reach out to us by writing email. Dinesh, can you please share the email with the participants? So we'll be sharing an email address where you can send your queries after the seminar. Thank you very much and have a great evening. Thank you, Dr. Marc, and we wish you have a great day. Thank you, Aidan.
My pleasure.
Thank you, Dr. Marc.
Thank you, Amit.
Thank you.
Thanks, Aidan. Have a great day. Bye-bye.
Bye-bye.